Good afternoon and welcome. My name is Brad Antle and I am the chair of the NVTC Impact AI Summit and the executive chairman of OSIS Networks. On behalf of my co-chairs, Charles Onstopp III from SAIC and Tom Wotecki from Virginia Tech, welcome to NVTC's Impact AI Summit. We're delighted that all of you have joined us for the second day of this fantastic event. NVTC is our trade association representing the Capital Region's tech community. We unite, educate, and advocate for our members to advance a thriving tech ecosystem where we live and work. This region offers a unique set of artificial intelligence assets that no other region in the world can match. Fortune 1000 companies, entrepreneurs, and investors, proximity to and expertise in serving the federal government customer, a highly educated workforce, an unparalleled research infrastructure, and top academic partners. This ecosystem is dedicated to developing innovative AI solutions for both commercial and public sector customers, and that's what we're here today to explore and highlight. We have a very exciting program for you today, but before we invite our first speaker to the screen, I want to thank the companies and individuals who have made today's summit possible through their financial sponsorship and also their guidance and expertise as members of our event steering committee. Our platinum sponsor is Accenture. Our gold sponsor, Ericsson Immigration Group. Our keynote panel sponsors, Digital Realty, Dovell Technologies, SAIC. Our silver sponsor, Fairfax County Economic Development Authority. Program sponsor, George Mason University. PR Marketing Advisor, the Merit Group. Public Policy Advisor, Hunt and Andrews Kurth. Our marketing agency advisor, O2KL, and our media partners, iHeartMedia, Scoop News Group, Washington Technology. All of these sponsors have made the content today possible with their generous support and guidance. I would also like to thank NVTC's business partners and academic partners for their year-long support of NVTC. They are Booz Allen Hamilton, Center for Innovative Technology, Consumer Technology Association, Deltek, Dominion Energy, George Mason University, Inova, KPMG, Maximus, Microsoft, Nobless, Northrop Grumman, PenFed, Pillsbury, PNC Bank, SAIC, Venable, Verizon, and Virginia Tech. A quick reminder for anyone who wants to tweet from today's event, we'll be using the hashtag ImpactAI. At the conclusion of today's presentation, we will have a Q&A session with our speakers that will be open to any of the subjects that were presented today, and we will try our best to get through as many questions as we can in the time available. Please use the question button at the right of your screen to post your question throughout the presentation. Please identify the speaker your question is for, and don't wait until the end. Now, let's get things started. To kick off our program, I'm delighted to introduce today's first keynote speaker, Dr. Susan Gregurick. Susan was appointed Associate Director for Data Science and Director of the Office of Data Science Strategy, ODSS, at the National Institute of Health in 2019. Under her leadership, the ODSS leads the implementation of the NIH Strategic Plan for Data Science through scientific, technical, and operational collaboration with the Institute's centers and offices that comprise NIH. She was instrumental in the creation of ODSS in 2018 and served as a senior advisor to the office until being named to her current position. Susan was previously the division director for biophysics, biomedical technology, and computational biosciences at the National Institute of General Medical Sciences. Prior to joining NIH in 2013, she was a program director in the Office of Biological and Environmental Research at the Department of Energy. Please welcome Dr. Susan Gregurick.
Thanks so much, Brad. It's really a pleasure to be here today to talk to the committee about ways in which we can address present and future challenges and opportunities in artificial intelligence. Before we begin, I just want to acknowledge and thank one of my mentors, Dr. Phil Bourne. He was the first Associate Director of Data Science at the National Institutes of Health. He is responsible for all of the work that we've done in BD2K, our Big Data to Knowledge effort, as well as the work in fair data principles and practices. He's passionate about data science and open data science, and now he has new opportunities for educational opportunities as he is the Stephenson Dean, the School of Data Science, as well as a professor in the Department of Biomedical Engineering at the University of Virginia. So thank you so much, Phil, for all the work that you've done for NIH and for the community. It really truly is standing on the shoulders of a giant. AI is certainly not new, as all of us know. You know, it dates back perhaps as early as 1694 with Pascal and the first mechanical calculating machine. Moving on to Alan Turing and the Turing test for machine intelligence in the 1950s, and then a really important workshop at Dartmouth where the concept of artificial intelligence was coined, and I think that's sort of recognized as the birth of the field. There was a sort of AI winter there between the late 60s and the 80s, due mostly in part to the lack of funding from some of the big funding agencies. But then we see a resurgence in 1980, but certainly in 1997 when Deep Blue, IBM's machine, beats world chess champion Garry Kasparov. And then my favorite in 2002 with the invention of the Roomba. And we see even more activities with IBM winning Jeopardy, and then the personal assistant of Siri. And finally, in the later part of the 2019 and 2020, when we start to see the emergence of AI in biomedicine, the first FDA-approved device is in 2018. It's a device to detect diabetes retinopathy. And then in 2019, successfully diagnosing X-ray cancers and CT scans. What will people say was the biggest breakthrough for AI in 2021? My guess is it will be Ingenuity, the first remote AI-enabled flight on Mars. Probably we all recognize that artificial intelligence applications are very prevalent throughout our everyday life, from e-cars to mobile apps and locations to even in devices in medical settings. What are the visions for the future for AI? Well, if you read the IT Buzz Network, World predicts that by the end of 2025, there'll be about 175 zettabytes of data worldwide. That's all data, streaming data, medical data, every kind of data, mostly in the cloud. And a zettabyte is about 137 billion iPads. So this is a lot of data, hold mostly in the cloud. So what we can do with it is unlimited. And at the same time, computing architectures are adapting to AI. There's a new chip that was announced not too long ago from NVIDIA. It's Grace's ARM band processor. So AI-enabled computer architectures keeping pace with the data developments. In terms of biomedicine, AI is integrated, as I said, in every realm of society. In biomedical and clinical research, AI has the potential to improve health and healthcare systems in ways that will positively impact all of us in the future. And this goes beyond personal devices and personal FDA-approved devices to AI capabilities that help detect health and health disparities. Some of the promise of AI is not just in the reanalysis of individual data sets alone, but it's in the comparative and correlative relationships among data sets. And having the ability to infer and model relationships on aggregated data sets is one of the more difficult components of data interoperability or data for AI. And this is really one of the grand challenges that we see at NIH to set forward on. The future of AI also promises to help understand causality. understanding explainable AI may help machines teach humans rather than humans teaching machines through learning algorithms. Advances in semantic artificial intelligence and inference algorithms could help harmonize different models and in fact make it possible to integrate data sets across federated resources. We see this happening in the AI literature at the moment, where semantic artificial intelligence is really taking off, but there's also the merger between semantic and symbolic AI, which promises new and interesting hybrid approaches. And finally, one area that does remain understudied within the AI realm is the ability to use AI to improve health for racially and ethnical minority populations and reduce health disparities. This capability is work that NIH could build upon and has done with our modern and fair data ecosystem, and it's a natural extension of the work that we've outlined in our strategic plan for data science. If you're looking for a grand opportunity in AI from NIH, I think this might be one of the areas that we would certainly like to explore. This is a little bit of what's happening right now, or what's happening in FY21 in artificial intelligence. And here, artificial intelligence is defined by the NIDARD R&D subcommittee. So it's a little bit narrow in scope. It has to deal with computer systems that perform tasks that have traditionally been required by human intelligence. So it could include machine learning. It could also include computer vision and natural language processing, and intelligent decision support or healthcare decision support systems, as well as autonomous systems. And 2020, which is the last year that I have solid information for, we're right now in 2021, so we're sort of evolving our funding in this area. But in 2020, we funded approximately $113 million in artificial intelligence, and what you see in the pie chart is a breakdown in terms of the institutes and centers at NIH that support artificial intelligence, and it won't be too surprising to you that the National Institute of Aging is the biggest funder of AI, and that's because they have a huge push in AI for Alzheimer's. And you can see the other institutes who do have significant investments in artificial intelligence, including cancer, for example, as well as NIGMS basic research. What are some of the current science drivers? Certainly empowering Alzheimer's is the biggest driver, but there's other drivers such as the multi-scale analysis of the 4D nucleosome, predicting guidelines for broad spectrum antibiotics, certainly something that would be of interest even before SARS-CoV-2. Deep learning approaches to improve diagnostic accuracy. This includes diagnostics from imaging, using AI to screen for clinical effectiveness, understanding healthcare records for cohort discovery. This is another big area for AI, and then basically high performance text mining. What are some of the challenges in AI? These are challenges that were identified by the Advisory Council to the Directors ACD AI Working Group. This is dated back in 2018, but here's what they told us were some of the biggest challenges. Data is a challenge, ethics is a challenge, and then training people is a challenge. Their challenges were outlined in terms of data. Many data sets lack the crucial metadata, or in terms of demographics and collection methods. It really does limit us to detect and correlate and correct for batch effects. Many of the data sets that are funded by NIH were collected for narrow purposes. However, what we need is data that is more aggregable and integratable for larger purposes. It's not unreasonable that the data could have biases and or lack of representation. They might have small sample sizes, and they might, in fact, have prohibitively restrictive access policies. This is certainly true for genomics data. What are some of the challenges that they identified with respect to ethics? Include oversight and investigation into the use of ML tools that have not caught up with the proliferation of their use. This includes concepts in terms of fairness and equality, privacy and consent, reliability, safety and security, accountability, and education. Without new and coordinated efforts, machine learning can reinforce blind spots and bias in the data, and that these really do create outcomes that are not necessarily correct with what the data should support if it were unbiased. In terms of challenges with people, many biomedical experts often struggle with AI, and so developing a collaborative effect was something that the working group identified. It really does require collaborative teams of experts across multiple domains to realize the full value of artificial intelligence for biomedicine. However, experts often speak different languages. Artificial intelligence and computer science experts talk in different ways from biomedical researchers. So having a ways for us to cross-pollinate and to work together is something that the working group said was a priority. Educational systems from high school through grad school and beyond and professional landscapes are often disjointed. AI conferences do not necessarily include many of the biomedical researchers and vice versa. And so we do need to provide sufficient opportunity for cross-pollination. So this is the full report. It's hyperlinked there below. It's worth reading. And here are some of the recommendations. Support flagship data generation efforts. Develop and publish criteria for ML-friendly data sets, those data sheets, as well as model cards for algorithms. Talk about how data was trained. Publish consent and data access standards for the data. Publish ethics principles for the data and for the algorithms, and develop new curricula to attract ML biomed experts. And think about piloting different ways to bring in trainees and fellows that are ML biomed experts, and develop cross-disciplinary collaborative teams. So what are we doing to address those recommendations? Actioning the idea of biomed or AI. I want to talk about two different efforts, Bridge to AI, and then a sustaining AI efforts across NIH. So the Bridge to AI program is a way to really address the need to create those data sets that are AI ready, as well as bridge across different teams. So we have envisioned data generation centers. These will create flagship data sets and the necessary tools and the ethics rubrics to drive AI biomedicine. The centers will be focused on data acquisition, team efforts, ethical standards, tools, and workforce development. We also envision a bridge center. This is a way to integrate across all of our data centers to develop evaluation tools and dissemination activities, as well as cross-pollination teams. And you can see that the cores will be in teaming, ethics, standards, tools, and workforce. This is a visual of what we're envisioning. Again, it's focused on data set generation, so the data sets address grand challenges. There are at least 3 to 5 of them, and then cross-cutting efforts and coordination and ethical rubrics and standards needed for AI development, and any of the AI necessary tools, and then workforce development. We have just published the notice of intent to publish these funding opportunities. The first centers will be other transactional authorities, and the bridging center will probably be a U mechanism. I do encourage you to look out for the funding opportunities when they are published by monitoring the websites noted here. Those are efforts that are through the Common Fund. Bridge to AI is a Common Fund effort. It'll be 5 or potentially 10 years in effort, but after that, it will have to transition to a sustainable model of funding. And so some of the work that we're doing to sustain AI in training and ethics and bias and transparency include work from my office in 3 big areas: addressing the workforce gap in data science for biomedicine, addressing ways that we can enhance ethics, bias, and transparency for people and for machines, and finally improving and augmenting existing IC Institute-supported data sets to make them AI ready. So enhancing the concept of FAIR and AI-ready data sets. I'd like to talk about just a few of these. We have a new supplement out for NIH existing awardees to focus on information science and artificial intelligence at the interface between these domains. This is to create educational opportunities and competencies through skills and curricula development, developing those training modules and integrated training plans, bringing together computer science, library science, and biomedical science. So the notice is out, and the applications are due May 14th. We also want to improve the readiness of NIH-supported existing data. So this is imputing AI metadata and FAIR data into existing data. This is a collaboration that brings experts in biomedicine, data management, and artificial intelligence together to really think about ways in which we can create better data from existing data. The notice is out, and it's due on May 26th. Where can we go in the future? So one of the things to think about is that it's true that AI is integrated in every realm of our society. It has the potential to improve health and healthcare systems in positive ways, but how can we really enhance that? Artificial intelligence and data science are interwoven and are quite inseparable, but are we paying enough attention to the data side of AI, from the activities that you've heard in creating new AI data, as well as improving existing data? Is that enough? Are there things that we're missing that we really should think about? The promise of AI is not, again, in the analysis of individual data sets alone. It's often in the comparative and correlative relationships that you can infer from AI. Having the ability to model and infer those relationships is one of the more difficult components. And what can we do to really enhance a greater AI data science capability? Other things to think about include, are we training the next generation for the challenges of artificial intelligence? Is it enough to just bring together collaborations between computer information and biomedical data sciences, or is there something that we're missing? And finally, for us, me personally, one of the most important areas that remains understudied within AI is the work on improving health for racial and ethnic minority populations and reducing health disparities. How do we remedy these challenges? How do we ensure that the benefits of AI are shared by all and contributed by everybody? Some other grand challenges democratizing the benefits of AI include addressing bias through broader representation in the data and broader engagement in the applications, including more inclusive model testing. Building that capacity between computer and data infrastructures could lower barriers to entry. Going beyond correlation to causation is another grand challenge. It really addresses the underlying effects of explainable AI and causal frameworks, and thinking about ways to integrate mechanisms and data-driven approaches. I want to thank you again for allowing me to come today to participate in the panel. You can learn more about the office, and there's a nice webpage that has been designed for artificial intelligence that hangs off of this link here, that I hope that you'll explore to learn more, not only about what is happening in the Common Fund and in my office, but what's happening across NIH in artificial intelligence, which I can tell you is quite a bit. And with that, I again want to thank you, and I'm looking forward to the panel discussion.
Thank you, Susan. That was absolutely fascinating. I would like to introduce Rod Fontecilla from Dovell's Technology, who will introduce our panel.
Thank you, Brad. My name is Rod Fontecilla. I'm the Chief Innovation Officer and Chief Data Scientist at Dovell Technologies. We are pleased to be a sponsor of this event and a longtime supporter of NVTC and its initiatives. Dovell is a trusted government partner that blends deep domain expertise with advanced technologies to help our customers solve complex problems that improve, protect, and save lives. For more than 15 years, Dovell has supported agency missions to improve public health, strengthen research and IT capabilities, and optimize operational outcomes. Our team is comprised of 2,200 personnel spread throughout the country, are proud to support federal agencies in health IT, life sciences, public safety, and grants management. We're dedicated to helping our customers make smart, insightful decisions that drive meaningful change in the world. We do this while building an innovative and collaborative environment where domain experts work alongside technologies for purpose-driven initiatives. Now, it is my honor to introduce our panel on AI in health, the good, the bad, and the ugly. First, Let's welcome our panelists. Dr. Gil Alterovitz is the Director of National Artificial Intelligence Institute at the U.S. Department of Veteran Affairs. Gil is working on building AI research and development capacity to help veterans. He has led national and international collaborative initiatives for developing novel informatics methods and approaches for integrating clinical, pharmaceutical, and genomic information from research to point of care. He has produced over 50 peer-reviewed publications and 3 books in the field. Next is Dr. Gerhard Picher, is the CEO at Elder Research. Gerhard enjoys predictive analytics and data mining, especially related to the areas of fraud detection, financial risk management, and healthcare, working with people, leading change, and managing complex projects to timely success. His work experience spans private, government, and international sectors. Next is Swathi Young, is the Chief Technology Officer at Integrity Management Services. She's an award-winning CTO with over 20 years of experience across organizations such as Amtrak, SunGard, GE, and Oracle. She's a practicing data scientist who helps transform organizations through innovative AI and machine learning solutions. And our moderator is Dr. Phil Bourne. Phil is a Stephenson Founding Dean of the School of Data Science, Professor of Data Science Biomedical Engineering at the University of Virginia. Prior to that, he was Associate Director for Data Science for the U.S. National Institute of Health and a Senior Investigator at the National Center for Biotechnology Information. In his role at NIH, he led the Trans-NIH US $110 million per year Big Data to Knowledge research initiative and contributed to data policies and infrastructure aimed at accelerating biomedical discovery. Phil, over to you.
Thank you very much, Rod, and welcome everyone. I'm looking forward to hearing what everyone has to say. Before we get into the good, the bad, and the ugly specifically, I thought it would be useful to do some context setting with our panel here. So it would be great to hear from each of them just briefly for a couple, 5 minutes, no more, on just really their role with respect to AI in healthcare. Then we'll get into some more detailed questions. But Swathi, would you like to go first, please?
Sure. Thank you for the opportunity. So there are a number of use cases I have worked on using AI and machine learning in healthcare, and I can state at least 3 of them. Number one, when the pandemic hit us last year, one of the things we observed is a lot of organizations were planning to reopen and reopen safely. So one of the things we had designed is CODA, which is a COVID-19 digital assistant. So the biggest challenge a lot of not just healthcare providers, just businesses were facing is how to keep a low-touch environment, maintain a low-touch environment at the entry point of their offices. So CODA is like a chatbot and an app that they can enable their visitors, employees, and contractors coming into buildings. And they would do basically healthcare screening instead of actually having a paper-filled form or having a personnel there. So we use natural language processing, obviously, and ask pertinent questions. Now we could customize this further to include even vaccination information. So that was the first use case. But also being a strategic leader in lung cancer research, one of the recent use cases, and Dr. Brett Berlin is aware of this use case, is how to use machine learning and vision detection to find the subcutaneous fat and its impact on lung cancer surgery patients. So that was involving, obviously, a lot of convolutional neural networks reading CT scan images of publicly available data and then sending it back to the hospital to run it on their images as well. What we came to know in conversations with the radiologist is that they were spending this time manually to measure the subcutaneous fat using some traditional software, but it took many, many hours. At least from what our conversation led to, is it takes anywhere between 10 to 16 hours for a radiologist to measure all the fat. and also understand its impact to lung cancer surgery patients. So that's a pretty interesting project, which directly impacts patient outcomes as well. So those are the two major projects that I've recently worked on.
Okay, thank you, Swathi. That was very good. We'll come back to that. I'm sure that there's COVID intersections between all of us as in what we're doing and moving forward, and I think it'd be a good idea to come back to that. But let's hear from Gil.
Yeah, well, thank you very much. And there actually have been a number of different areas, including some that are similar in terms of interacting with some of the COVID items. So, what we're charged with is really kind of developing that artificial intelligence research and development capacity over at the National Artificial Intelligence Institute over at the VA. And when you think about that, it really comes down to both the people, and we'll talk a little bit about workforce in a little bit. The types of research that you can pilot, and a lot of that rests on the fuel for AI, which is essentially the underlying data. The VA is actually the largest integrated healthcare system in the country, over 9 million veterans in the system. So there's a lot of data in the electronic medical records that we could use to help that population. And besides the medical records, the actual, clinical notes and so forth, there's lots of other information, some of it linked or within the record, whether it be over 1 billion images that are required each year, to new ways that we're looking at using other technologies like wearable information to integrate and build that fuel for AI. There's there are hundreds of different projects. We're actually doing an inventory of different use cases right now. And across, the country, there are many different use cases. But the one that, just because COVID was mentioned, that we're working on as sort of, we've got sort of core projects, associated projects, and affiliate projects is around COVID-19 and prognostic modeling around that. So, and doing it in a way that leverages explainable AI so that the clinicians are better able to understand why the AI is making those recommendations. And that's really critical. We've seen toward adoption, is at least, within the clinical setting, but in any setting, really, when you have a new technology. So focusing on trustworthy AI came out in a recent executive order, and understandable AI is referred to in there, and explainable AI aspects as we think about kind of more in the community for certain parts is going to be very useful. And so that's those are some of the ways that we're trying to work together to build that R&D and have it be used directly to help the population operation.
Yeah, thanks a lot for that, Gil. As I'm sure we all have, I've heard the expression, data is the new oil, data is the new soil. Now data is the fuel for AI, which of course is absolutely true. So thanks for mentioning that, because I don't think we should be just partitioning AI per se, but we should really be looking at it in a larger context, which of course relates to the data, and of course my own personal interest in data science. But that's not why we're here, but we're here to hear from Gerhard. So Gerhard, give us your bit of contextual opening.
Sure, Phil. Thank you so much. It's an honor to be with this panel. Elder Research has been around this is our 26th year doing machine learning and learning how to do it better. In healthcare, more specifically, we've been involved in a number of different areas, and I'll just touch on 4 of them. One is around human behavior and healthcare outcomes and how those are impacted, how our behavior toward treatment protocols and things affect the outcome. The other is the treatment protocols that are chosen by physicians and how they impact the healthcare outcome and how that can be improved while actually reducing cost. It's almost a surprising result that those two go together so well. Another place that we've done a lot of work is around genomic research coupled with wearable devices. Can we predict the onset of acute diseases and other diseases much earlier in the process so that we can start treatment protocols earlier and therefore have better outcomes, again, focused on outcomes by earlier detection. The third area that we've worked on is really logistical in nature, and this is really an aid to clinicians, is things like photon radiation and choosing a set of angles for the photon radiation that minimized tissue damage. It was a very time consuming for radiologists to do this, maybe in the 5 or 6 day time frame, but by using AI and images of the patient and categorizing tissues from those images, you can significantly reduce that time to less than a half a day to choose an optimal set of angles for photon radiation. And the last area that we've worked in is really around, risk transference. So we're in episodic care now or moving toward risk-based. I guess there is quite a bit of risk-based care already, and capitation, things like capitation. So how do we do that well so that it's a win-win for the patient, but also the providers having to understand and manage that risk within the healthcare system and improve outcomes at the same time. So those are the primary areas that we've done work.
Yeah, thanks for that. Actually, it segues a little into the notion of cost effectiveness, but I'll come back to that in a minute. What I was going to ask the panel, and please anyone step in, I think at least if not all of you, certainly two of you mentioned the interrelationship of activities you're doing with respect to COVID. I'm just wondering more generally how you see post-COVID. We all talk about how life's going to be different in post-COVID. How is AI in healthcare going to be different post-COVID? It strikes me that we're going to see some accelerations, in part because of the way we've collected large amounts of data in unprecedented ways. That opens up opportunities. But I'm just interested in whether you see things are going to be different with respect to AI in healthcare. Anyone just chip in?
Sure, I can start. I have some thoughts. So one of the other use cases I had not mentioned was also using machine learning for fraud, waste, and abuse in healthcare fraud. So one of the things that COVID-19 has done, and we all are aware of it, has accelerated adoption of telemedicine. So previously, I do know 5 years back or maybe 3 years back, my doctor's office had a telemedicine option. And when I chose that, they said, no, you have to come to my office. But today they want to use telemedicine more and more. And I think one is adopting more usage of telemedicine, even for use cases like we have seen usage of machine learning and vision processing in diabetic retinopathy. And I think it was always citizens or common people want that convenience of not walking out of the door, but now healthcare providers are giving them that convenience, so much so my husband, who's an eye doctor, says, when will my job be taken away by AI? And we've had a lot of discussions around that, but he says if people want to sit at home and to actually I can check their eyes in a convenient manner, it's only the edge cases or the complex cases they have to walk in office. So one is telemedicine. I think it's going to be adopted very widely. But with it, number two, that's interrelated is with wherever there is new technology, there is fraud that's going to happen. I think the law also should follow what are the rules and regulations around telemedicine as well. So going back to the use case of using machine learning for fraud, waste, and abuse in healthcare, fraud and healthcare claims fraud, I think that will lead to that conversation around whether it's policy around telemedicine and billing around it, or even if there is an impact that things could be hacked by introducing foreign things, because wherever there is money, there is fraud that follows. So that's something I'm thinking in the post-pandemic world. And healthcare itself, I think, is at the cusp of disruption. We have seen Amazon slowly segueing into that space with some pharmaceutical reordering of pharmaceutical orders and so on. But I think I know of a number of startups coming up that are opening up shops just for a nominal amount without any insurance, providing healthcare services. Of course, they are heavily regulated, so it has impact on policy. And us sitting in the DC area are very well aware of the policy comes after innovation. So I'm seeing those three areas: adoption of telemedicine, virtual visits, what have you, especially among the younger demographic, and insurance is going to be disrupted in a huge manner as well. So there's direct impacts and secondary impacts, and then the tertiary on fraud and other things.
Yes, you're definitely hitting on some of the bad and the ugly there of our session. We'll get to more of that, I'm sure. Gerhard or Gil, do you want to add anything with respect to COVID's influence on the future of AI in health?
Certainly, yeah. So first of all, I agree with what Swathi Young has said. I think those are some great points, especially the telemedicine. That is sort of like a box that once it's opened, and it will remain open. It will expand. The one thing I wanted to add on that, which kind of maybe is that once it's open, people think of telemedicine as basically they're trying to kind of emulate what it's like to be at a doctor's visit. That's kind of the first generation, right? But the future of telemedicine, it's kind of like, the internet. At the beginning, they were trying to emulate how people would read a newspaper, online. But that's not how we see the internet today. We don't think about it as like reading a newspaper. We're using the internet to record video, to watch movies, to play games. I mean, so many different uses to do, telemedicine, right? So that's what we call telemedicine today. It's going to be very different in the future, and AI will play a central role there, is what I believe. So, for example, in a telemedicine, you don't have how do you do all those different measurements, right? You're going to start to see either sensors, wearables, robotics, where the patient can be empowered and interact in some way, and all of that additional data is going to need to be quickly analyzed and given to the clinician to be able to make a decision on that. And so that's where the AI is going to take a large role. And I think that just COVID in general will make it easier or make it faster to adopt new technologies, not just telemedicine, but all organizations will be more open to adopting new technologies like AI. And the final one, I want to emphasize again, I think that aspect on regulation is really going to be a big one. We started to see a little bit about that. There were a few new codes that were authorized for telemedicine right before COVID, actually, right? And then afterwards, a lot of different kind of reimbursement models are really coming about. And I think that will really change a lot of things in how AI and can integrate different types of data together that can be reimbursed in the future to make things both more cost effective and higher, more, give more accuracy. So so that's what I would say.
Thank you. Gerhard, did you want to add anything to that?
Sure, a couple of things. I'd like to touch on one thing, and that Gil and Swathi talked about, and this is really around the healthcare data and things like wearable devices. I wear a Garmin that has all kind of information that would be helpful to my physician, especially because it records it over time. You get a more complete record. But it raises one of the things that I think can hold back the transformation a little bit in healthcare or slow it down, and that is that our records are locked in different systems that don't talk to each other very well. We're still trying to overcome the issue of that, and I think slowly moving toward the ownership of records being with the patient and carrying it around like you carry around your health card or your wallet will really unlock that transformation. Just Gerhard's opinion on that. Around COVID, I'd like to maybe touch on a little bit of a more controversial topic around COVID. And we studied the data from the very beginning and built some models around this, both for the Prime Minister's office in UK, as well as in the US. And it touches sort of on an ethical issue, I think, about how we use the data. Are we using the data in informing people with good factual information about what we know or don't know? Or are we using the data to manipulate people and create fear and not an understanding of risk around COVID, as an example? And COVID is the most recent. But I raise that question because I feel like in many cases, based on the studies that we did and the data that we were looking at, we knew a lot more before it was ever announced by the government. And the risks, as we assessed them, were much less. Part of the risk was generated by the scorecard we kept of cases and deaths that wasn't put into any kind of context or have a case fatality rate type of measurement that really put that into better context. And I feel like we did a disservice in the way that data was presented. And I feel like that's a little bit of an ethical issue, and I know that's controversial. Some people will have issue with that, but I think that's the kind of topics that make these things interesting, is to debate and talk about those. So that's my view of COVID. I felt like we were more manipulative with the data than honest about the data and giving people a real sense of what was going on so they could make wise choices. And so because of that, we ended up maybe with restrictions that seemed overly burdensome. So.
Actually, it made me think of the parallels, and this is actually really part of it, of what you just described in terms of fake news. But it's really the unfortunate opportunity to have fake health, and by virtue of the inappropriate manipulation of data. One other thing that I just thought about in the context of just the things that are happening with respect to COVID in particular, but where they apply more generally, is because that suddenly we've got this digital footprint that we never had before. So telemedicine is an example of that. In education, we think about that, but suddenly for the first time, every word that's uttered effectively in the classroom, obviously the virtual classroom, is now available as a piece of data for some form of effective use. And of course, that has lots of ramifications around misuse as well, to Gerhard's point and well, all of your points. But there's also huge opportunity to improve the quality and to extract useful information for improving healthcare that would not otherwise be the case by virtue of having that digital stream, provided, of course, we can figure out how to manage it effectively, which actually takes us to the next point, which I will go around. I'll ask Swathi first, and we'll. But really, is any thoughts you have about cost effectiveness of what these new AI in particular approaches going to bring to healthcare, or is in fact the cost going to go up? I mean, we are in a situation where, from my understanding, virtually half of all the healthcare money in the world is spent in the United States, and yet we rate somewhere in the low 30s in the overall quality of healthcare. So we don't want it getting any worse. Do you see it getting worse or better?
I'm hopeful that it will get better. And I think one of the analogy I can think of is telecommunications, right? Where I come from, I grew up in India. And it's interesting, India, we did not have actually landlines because it was government owned and we had a long wait time. So people did not have telephones. And suddenly every street vendor has a mobile phone in India. But also the fact that we had very high cost to make a call, and now the calls are free and we are only charged for data. So I'm thinking healthcare is going to go that route with or without the usage of AI, because you're right, Phil. United States being very, very backwards in terms of providing good healthcare and improving patient outcomes and so on. So I think it's ready for disruption. And to Gerhard's point about data, thankfully, I think there are some aspects of healthcare that can still be controlled with the use of HIPAA, although I still debate the ethical AI principles should be followed, like Gil mentioned, the trustworthiness of the AI, the explainability of the AI, and so on. But regarding the cost effectiveness, if you're not able to, if you're going to not drive to a healthcare facility, it is going to be the convenience. And there are many players that are going to come out, startups in the space. We already saw, in fact, during COVID, we saw the venture capital funding for startups in healthcare was hit the roof. So that's an indicator that there's a lot of investment. So there's going to be, I believe there's going to be a huge disruption in terms of whether you're using sensors or even introduction of robotics in a hospital setting as well. So I'm hopeful for a patient. The insurance costs will come down. The convenience will hopefully go up. And talking about, Gerhard also mentioned the interoperability, right? If I am changing my healthcare providers, whatever history I had today. It's a huge challenge. In fact, I changed my healthcare provider for my little son, and I had to go to the previous doctor's office and actually fill a paper form to get all the history data that I have to submit for his school since he starts kindergarten this year. So there's all these, inconvenience caused that I have to fill all the forms. So I'm thinking there is this huge opportunity in terms of reducing healthcare costs, in terms of transparency, of interoperability of data, in terms of just managing costs in a more efficient manner so we don't have to pay through our nose for healthcare insurance.
Mm-hmm. Thank you. I was actually thinking that in Gil's case, he has a sort of, he probably doesn't see it this way, but the VA is a sort of controlled environment. I wouldn't say it's like a social medicine environment, but I'm interested how you see cost effectiveness in that environment.
Right. As you said, there are, so I think with the VA, when you think about it, it is its own payer and provider, right? That is correct. But we also need to keep in mind that veterans sometimes, especially older ones, may also use CMS for certain benefits, drug prescriptions and others as well. So and also veterans can use the community care, which is another kind of area that through the Mission Act and so forth. So it is not a completely closed system. Overall, I think this question is sort of, I think it reminds me of what people were saying about, for example, COVID and what's going to happen with the economy. Is it going to be a V-shaped recovery, a W-shaped, all these different shapes, L-shaped? It turns out it ended up, a lot of people are now thinking about it as a K-shaped recovery, where some sectors are going kind of up and some are not going up quite as quickly. And I think actually that's how it's going to be with AI and costs. So let me tell you what I mean here. So, for example, in automation and productivity, all of the pressures are toward optimizing costs and saving costs. Otherwise, that AI is not going to be implemented, right? Well, why do it? Because that's the metric, right? But on the other hand, when you think about diagnosis and different areas that are billable, and especially, where, if you look outside the VA in places where it can be billed, and you're being rewarded based on using or if you're a concierge service, based on getting the best accuracy, there's a different metric there. And we've seen this with other technologies before, MRIs, others. They actually increase costs, right? Because people want to go for the best care, and it's in terms of in economy, you think about elasticity. People will pay anything to be healthy because it's just something fundamental that it's hard to put a value of money on. So that's why I call it sort of this K-shaped cost curve is what I see going to the future. One, lowering the costs for ones where I think AI is going to make a huge difference, maybe even more than in the diagnostic and prognostic area, at least initially, even within healthcare, whether it be processing forms, productivity, and so forth. And then one where, so that one will be lowering the costs, and then the increasing costs when we think about ones where things other than cost are going to play a role, whether it be getting accuracy, increasing revenue for that organization because of how they divide up and do codings and so forth, to get the best care that they, in their perception, based on new technology.
Thank you. Gerhard, I'm going to move us on a little, but keeping somewhat on the same theme, but actually bringing in something else that you mentioned, which is close to my own heart, which is this diversity in healthcare systems, particularly as it relates to things like maintaining the electronic health record, but even beyond that in terms of standardization and so forth, which obviously affects the cost effectiveness. But you brought that up, and I'm wondering whether you could say a little more about that and how you see that affecting the effectiveness of these new technologies when so much of our infrastructure seems to be a bit of a quagmire. Sure. Perhaps you disagree with that.
No, I don't disagree at all. And it actually gets at one of the hidden costs of healthcare that we hadn't even discussed, and that's medical errors that cause serious health or death. and how many deaths that actually causes in the United States each year. And many of those deaths are caused because of a lack of coordination among physicians. And we've had Kaiser Permanente, who has demonstrated how coordination around healthcare givers can improve outcomes and save lives. And I think this is the real cost underlying us not being able to share that information readily among all the different providers that we might have in the network. And to me, that's the real human cost of this. In all the work that we've done around this and around improving outcomes, we have seen a reduction in costs. That wasn't the goal of the projects we were working on. The projects were centered around how do we improve the outcome for the patient. But it turns out when you improve the outcome for the patient, you also reduce some of these costs. And part of the reason is models are like human beings. Human beings look at data from their past. You know, we look at patients that we treated in the past as a clinician, and we say, gosh, this is what we know about patients, but we have biases because we're human beings. And one of the most critical ones in medicine is what we call a recency bias. If I've seen a patient like this recently that has similar symptoms, I'm more likely to go to that diagnosis, even though there may be something more subtle there that I don't catch, because I may be looking at 20 pieces of data here. But an algorithm can look at that very quickly and say, hey, you might consider this diagnosis as well as that diagnosis for this reason. And we found, because the machine can do that in an unbiased way with all the millions of records of history, that aids that physician many times in making a better decision. So what we have seen is that cost and quality of outcomes costs have been reduced, quality of outcomes has been improved for patients through the use of AI. So I think overall, in the example I mentioned also in helping just radiologists pick angles for a photon, treatment, reducing from 5 days to 4 days. I think overall, in all of our 26 years of experience doing this, when it's applied properly over time, it will reduce cost for the industry as a whole. And it, I believe, will save lives for patients.
Thank you. My understanding related to the medication errors and medical errors that you mentioned is that right now 10 cents in every dollar of healthcare money goes on litigation or protection against litigation. So that tells you we should probably be doing something better than we're doing.
Cost savings.
Yeah. I want to switch gears a bit now to something that's really on my mind now in academia, because it's faculty hiring season. I wanted to ask about, from each of your perspectives, about the workforce pipeline, and really also about training of the workforce, because that seems like a critical part of the adoption of new technologies. But I guess, Swathi, let me ask you first. Are you getting all the people you need? Or is there a shortage? I think I know the answer to that already. But...
Right. We cannot have enough technologies in the whole world, or technologists in the whole world, to solve the problems we have. But you're right. It's a pipeline problem, and it's also the upskill and reskilling problem. It's education and awareness. So there's a lot of challenges around this. Number one, I get asked almost on a weekly basis, right from middle schoolers, how do I get into AI? So there's middle schoolers and high schoolers who are very curious, obviously, with all the STEM initiatives to get into AI. But I think the biggest challenge I have been noticing among my friends, family, and others who reach out to me is the mid-career professionals. So there is a lot of mid-career professionals who, first of all, are not aware of the opportunities that AI provides. I'm not talking about just STEM related. I could have done customer service or sales of a car. Is that selling as a skill? Can I use that skill to sell an AI product, right? Because you are enhancing your skills, you are going to earn more money, you are going to open up opportunities. So that mid-career profession is where most of the challenges are in first spreading awareness about what are the opportunities that AI brings to the table. And there is a huge gap in the job market for not just data scientists along the spectrum, product managers, solution engineers, sales engineers, what have you. So how do we bridge that gap between those available opportunities and these huge mid-career professionals who either lost jobs during the pandemic or who want to upgrade but are not aware of those skills? And secondly, even people who are having, like a data analyst yesterday asked me how could they get into data science? And you open Coursera and Udacity, you have all these courses, but people are still struggling to connect those dots as to how to upskill and reskill themselves, I think. In that way, organizations and government and nonprofits have a role to play. And me as a data scientist, I think personally, I have a role to play. I do my YouTube channel to spread the awareness and education. And organizations, obviously, larger organizations are investing in upskilling and reskilling programs. Number two, there are a number of nonprofits working with community colleges, but I think we need more of them. And number three, we can't say, okay, it's up to the individual to upgrade themselves. I think we have a social responsibility. If 10 years from now, most of the things that we're using and dealing with, starting from the time we wake up, is driven by technology, how do we ensure that the jobs of tomorrow are met by making sure that opportunities are becoming available to everybody?
Yeah, thank you. So, Gil, in the government sector, well, first of all, I would say what you said about mid-career people, I think is an important one. We certainly see in our continuing executive education offerings, as well as our online offerings, as increasing interest from that segment of the age group. Wish I was in it. I'm way beyond that. So, Gil, what about in the government? Are you getting all the people you need to work in this space?
So yeah, in the government, we have a number of different and similar and different challenges, I would say. So as Swathi was mentioning, overall there is a shortage of talent in this area. That's recognized. What makes sometimes a little different federal government is there's certain pay scales. This GS pay scale, which sometimes doesn't match to the level that's paid within industry. And so we end up attracting certain types of people who are really attracted to the overall mission many times. In fact, we have many veterans and people who've, in some ways have worked on that mission before. So that's kind of the first thing. So the second thing I kind of wanted to add on that is that when we, so what we have is really a number of different pipelines to bring in that talent, because no one pipeline, as you mentioned, it is really has the, and every part of it has different aspects. So we're looking, for example, we bring in academics. We have this interpersonal agreement type of mechanism that can bring in academics and give them certain types of appointments. So for part of the time, they can work together within the VA and with different VA collaborators. We work with other agencies that may have capacity as well, like Department of Energy and their strong computational capabilities and researchers across the national labs. There's a few agreements like that, for example. On now, then there's in-house talent, and that's the one that we're especially interested in looking at more. Most recently, we've been interested in kind of exploring that as well. So, for example, I personally got to know a pharmacist who used their analytical skills to, on their own, learn, develop, and implement deep learning in a way that then was leveraged within the VA. So that was fascinating to see that innovation happening there. And so reskilling, as Swathi was mentioning, is one of these pipelines within the VA. And across these, so when you have different pipelines, you have different things. You need essentially a standard way to know what are the skills that they have, right? Because people are applying from all these different routes. And so we're looking at how do you essentially establish, you may call it like certification or some sense, establish a standard of how to know what kind of AI they know, what kind of AI they could do, where they could fit within the organization. And so that's kind of the final piece that we're working on together and with others to do that, to around this challenging area.
Thank you for that. Certainly we in academia face the same problem as the government more generally, is you have to really want to come and work with us for other reasons. In our case, it's the desire to teach, work with students. Not perhaps a problem that elder research has, although some of our students go and work at elder research. So Gerhard, are you getting all the folks you need to work in this space, or and how are you mitigating if you're not?
No, there's always a great need, I think, and we work with great universities and programs like yours, schools like yours, to try to help that pipeline. But we're also doing a more focused effort around specifically STEM programs in high school. We view this as a long-term play to help get students more interested. And so we're personally getting involved in some of that at our leadership level with a number of STEM programs with a focus right now in the Raleigh-Durham area and the Northern Virginia area. Secondly, we've noticed in our industry, there seems to be a lower number of African Americans participating in our industry. So we've had a particular focus with building partnerships with historically Black universities and colleges. The third aspect that we've focused on is we acquired a company last year called statistics.com, and they really focus on the mid-career market with certifications that are accredited within the state of Virginia, as well as bachelor and master's degree programs that are completely online through Thomas Edison State University, that also focuses on mid-career people and people who have been in professional craft and trades, where they can bring those college credits to the training they've had in those trades. They can bring in as college credits to move them along faster toward a bachelor of master's degree. And internally, we work really on an apprenticeship basis where we can bring people in and teach them sort of what we might call the elder way. That sounds a little bit weird, but trying to upskill them as they're working on the job, more like a craft. I consider what we do as a craft. I don't think it's going to be replaced by machines. I know Swathi's a data scientist. There's a lot of thought and craft that goes into building good models and the features that you put into models. You can't just simply turn that over to a machine. And I guess the last thing I think I'd like to say that we've really focused on is what we call data literacy. In general, and I know that's a broad term, but in general, people don't think probabilistically. And what we found going into organization is somebody will present a chart that has some analytic on it, and they'll basically just say what the chart says. If there's an upward facing line, they'll say this is increasing. And what's frustrating to the person receiving that information is, what does that actually mean to the business? Can we get them to think about the meaning of that line and not just the line itself? So it's a different thought process. And that's what we mean by data literacy, getting people to understand probabilities versus things that are known. And then how do you think about that in terms of what it means to your business? So those are the areas that we focused on.
Great, thanks very much. We're
Can I add something? A thought just crossed my mind.
Very quickly, because we
very quickly, he mentioning data scientists. There is something called no-code AI, and they are looking at those tools. They're not going to replace data scientists anytime soon.
All right, so we're down to the wire pretty much. So I'm going to just ask you, each of you, just really in 1 minute or less, with respect to this question is, what is from your point of view, what is the best thing that's come out of AI in health so far? And what is the worst thing? No more than a sentence or two on each. Swathi?
Sure. I think the best thing is that there are enough use cases of improving patient outcomes. Especially, there is a use case of identifying breast cancer in women of color, diabetic retinopathy, and others. And the worst is actually the ethical use of AI, whether it is ensuring data privacy. That is number one. Number two is making sure that patient outcomes are not adversely impacted by algorithmic bias, and we know enough use cases of that. And thirdly, there are a lot of legal battles going on robotic surgeries gone wrong. So there are enough negative implications, but I think I'm hopeful that the positive will outweigh the negative.
Thank you. Gerhard, best and the worst.
Best. I think one of the best things is I've noticed that people have been more willing to share data, and this is so critical in improving healthcare outcomes, in that we have a better longitudinal record and more information, more fidelity in that information to be able to make better diagnosis and understand the outcomes better. And this is through wearable devices and all kind of things. There seems to be, in my sense, a more willingness to share that data. I think the worst is, and this is controversial too, but there's certain politicization of healthcare, and I think that's not helpful to healthcare sometimes. I think that could lead to stifling innovation. So I think we need to balance those things carefully. That would be my statement.
Yeah, well, that one we could actually have on a whole other session, which would be a lot of fun. All right, so I'm going to ask now, just to end off, or ending here, just give me a number. So my number was this year, 2021. My prediction was that I was asked, the prediction came when I was talking to the advisory board of the director of NIH about when predictive models would actually drive what we did in terms of experiment. It's more not directly, it's more about research than it is about healthcare directly, but I think the question is still a good one. So how long before that sort of thing happens? When is AI going to be the real driver for healthcare? How many years? Swathi?
I would say anywhere between 10 to 15 years, only because there is regulation that goes hand in hand with healthcare.
10 to 15. Gil?
Yeah, I had 10 as my number.
10, going down. Gerhard?
Wow, I don't know. It's a relative question. I think in large part there is AI driving healthcare now to some extent. I think that the real transformation happens when we can freely share information across all healthcare providers in a standard format. I think that's where the real transformative thing happens, and I think we're still 10 years from that.
Yeah, well, we'll see. Some things tend to happen much faster than you anticipate, and some things slower. So we'll see how it goes. Well, all that remains me to do is to really thank you, all three of you, for really what was, for me at least, an enjoyable session. Let's hope it is for those who have the good fortune of listening in. So thanks very much, and I'll hand it over back to you, Rod.
Thank you for that interesting panel. Next, Ashish Katru, the co-founder and president of Alterovitz Health, will present a tech talk on how AI delivers innovation, accuracy, and hope to healthcare. Ashish Katru co-founded Alterovitz Health in 2007 with a mission to provide a highly advanced yet intuitive care management solution for the healthcare ecosystem. He has successfully led the evolution of the company from a startup to an industry leader that has been noted twice by Becker's Healthcare as a top population health company to know. Ashish draws his leadership and process improvement expertise from a wide range of industries, including the manufacturing, consumer product goods, and venture capital, combining the best practices from each to improve the delivery of healthcare. Please welcome Ashish Katru.
Hello, good morning or good afternoon or good evening whenever this video is being watched by all of you. I am Ashish Katru. I am the co-founder and president of Alterovitz Health. Alterovitz Health is a health edge company. We recently got acquired by Blackstone and Health Edge, and now we are a portfolio company of Health Edge. But I thought before we start, I should give you a little bit of background about what Alterovitz Health does, so that we can center ourselves regarding this discussion on AI and how AI can deliver innovation in healthcare. I want to center us because I want us to know where we play within the healthcare ecosystem, and my views are going to be surrounding the ecosystem in which we operate because I understand that best. So the easiest way to understand Altruista Health and its platform guiding care is to know that we are akin to what an electronic medical record or a health record like an Epic would be to an hospital system or a Cerner, and I'm sure you guys have heard about those. Similarly, we are a core medical management or a care management platform for the payer world meaning the insurance world. So the guts of the operations, day-to-day operations in terms of patient management, those run on our guiding care platform, which is what Altruista Health provides to payers. And what this platform essentially is, it's a data hub of all the various patient healthcare experiences combined with analytics and workflow to be able to derive insights out of the data and then feed them to various different stakeholders involved in the care of a patient from a health insurer's perspective. So these would be the nurses, the doctors that the health insurer hires, or other allied healthcare workers that they hire. For example, sometimes people to work with social determinants of health challenges or activities of daily living challenges. These are the stakeholders that then can work within the guiding care ecosystem to be able to collaborate and coordinate and drive the care of a member in an aligned fashion in the hopes to arrest an avoidable hospitalization and improve the health outcomes of the member proactively. And it's good for the payer to do that. It's good for the member to experience better health outcomes. It's good for the payer to do that because they are responsible for the financial bottom line of their organization, and any money that can be saved for them through these better health outcomes for the members, because then they are not spending money on their hospitalization, goes directly to their bottom line. So with that, let's talk about AI and what kind of a future AI will have within the healthcare vertical. Obviously, all of us know that AI has been a focus of many different industries for a while now. I think it's on the adoption curve, it's moving along, where I see that pretty soon it's going to get a lot of adoption or notoriety within the healthcare ecosystem as well. There are obviously places, early adopters that have taken on AI and have adopted that within their universe and are already experiencing some of the benefits that this new technology can bring them. As you can see on the slide, there is about $4 billion that has been poured into healthcare AI startups in 2019 alone. So that tells you that this is a hot market, hot industry. Next slide, please. So here, what I want to focus on is how AI has been adopted in some of the use cases, and then I'm going to focus a little bit more on how it can drive better health outcomes within the payer ecosystem, the health insurer ecosystem. So we all know that a lot of rich information gets embedded in patient notes in a physician's office. And we, within Altruista Health ecosystem, will many a time through our connections with electronic medical records, we will bring these notes into our system. But unless a human processes them, there is not much you can do with them in terms of deriving discrete information that you could then feed into algorithms to derive additional insights. But using AI, the neuro-linguistic programming, you can actually derive structured data out of this unstructured data, which is hugely valuable. And that use case is already happening in many places. So how does Altrista Health work on the AI side? We decided that we were an analytics and a workflow company, but we did not necessarily have the right skill set in terms of the data scientists and all of the other people that are required to build cutting edge AI, next generation AI models. We decided that we are going to partner in this space and bring on the best of the breed from the industry in terms of AI models to our clients. So one of the entities that we have partnered with is Pulse Data, that recently got a big round of funding from US Renal and Bain Capital Ventures. Another example of a deal happening within the AI space. Actually, if you can go back one slide, sorry. Just want to focus on this slide for a while. I will ask you to advance when it's time. So, in that, what has happened is that we have brought on these capabilities to our clients. So some of the models that they have developed, one of them, for example, is the cardiac model that is represented on this slide, which can predict the possibility of an adverse cardiac event happening with 80 to 90% probability. There is another model that has even higher efficacy, which is on the CKD spectrum, CKD to chronic kidney disease to ESRD and stage renal disease. That model can, with higher than 90% accuracy for certain data sets that it has been trained on, that model can figure out which of the patients who has CKD today will progress to ESRD and therefore will require a dialysis within the next 12 months. The key here is that with such levels of efficacy, you can actually go after that person, that patient, that member with a very high degree of certainty, knowing that my intervention for this patient potentially could improve their health outcome and get them to a better place, because you have this crystal ball now that tells you that this person is going to have a severe outcome within the next 1 year, in the case of the CKD model. So with aggressive management of CKD early on, you can elongate the onset of ESRD by delay the onset of ESRD by more than a year, between a year and 2 years. Now, if you asked a patient who has the prospect of getting onto dialysis what they would do to delay the onset by 1 to 2 years, it's almost life-changing. They would do anything to be able to get to that place where they don't have to sit on a dialysis machine and they can still maintain a better, reasonably better lifestyle without it. And by the way, it turns out that it's a financially very good to the bottom line of the organization, because you on average spend about $5,000 on these dialysis per patient per month. So it's a savings of $60,000. Now, why is it game-changing? It's game-changing because we never in healthcare had this ability to predict with a high degree of efficacy at an individual level. All of the prior models that were built, and you can advance to the next slide now, please. So all of the models that were built before this in healthcare for creating these predictions were at best 30% or less, had an efficacy rate of 30% or less at an individual level. At a population level, though, when you aggregated all of those predictions, at a population level, they tended to be more than 99% accurate. So what that meant is that I can actually predict the spend for my population, hence the risk adjustment and payment by Medicare or Medicaid. Those who are aware of how the funding works, the states will aggregate all the data, and at a population health level with 99% or more certainty, they will know that your population in this next 1 year is going to cost this much, and therefore they will determine the rates for reimbursement, and that's how you will get reimbursed for your members that you are caring for as a payer, as a managed care organization. Very important to get your data right there, because if you miss certain data, then you will get, your risk rating will be lower, therefore your reimbursement will be lower, and therefore you will lose your shirt in that business if you get it wrong. But here, and then at an individual level, you only had 30% efficacy, which meant that 3 out of 10 individuals, when you do an intervention, you would be right at best case, 3 out of 10 individuals, which means that on those 7 individuals that you are spending a lot of money and effort and resources on in terms of trying to get them to a better health outcome, they didn't need the intervention in the first place. So the ROI on these models was not very good. But where it's game changing now is that 9 out of 10 times, or in the worst instances, 7 to 8 out of 10 times, I will know that I got the right member. And if I work on this member, I know then that I can prevent this acute outcome from happening, or at least delay in certain cases this acute outcome from happening. So this is just amazing. This is a development within healthcare that is going to fundamentally change how we interact with our patients within this ecosystem and drive better health outcomes. So if this is such a big news, then why isn't there a larger adoption of it, would be the question that you would ask me. The answer that I can provide to that is change takes time. Payers, insurers today are not wired to work so aggressively from a resourcing perspective towards these types of models. They are in the world of where they used to be, which is there's a lot of utilization management happening. There's a lot of authorization processing happening, which is being driven by regulators because they need to see that. So therefore, the entire ecosystem has to change in a new way, where just top down from the regulators themselves, the thinking has to change in terms of what they want to see from a care management perspective from payers. And when that gets driven down to payers, they will evolve and they will adopt these new the technologies, in this case AI models, which can allow them to predict with a very high degree of accuracy the patients that they can go after to create better health outcomes. Another very important development in the space that I believe is going to come with AI is the IoT side of it, which is the devices side of things. The challenge with the devices so far has been that devices can provide a lot of data, but in that data is tremendous noise. So for me to take blood pressure readings, or blood sugar readings, or weight readings, or any other types of data through these devices, there is a lot of false positives. And if I acted on all of those false positives, I would not be able to run a sustainable business. I would lose money. But through these ML models that can learn over time and can figure out which one was the signal, which one was the noise, we can have a very high degree of efficacy again from these IoT devices. So I believe that a day will come when payers meaning our insurers, will give us a device or set of, it is already happening with people living in home and putting devices in their home so that we can monitor them. But I'm talking about generally healthy populations. Like right now, I consider myself healthy. I will have a device on me that will collect data, and this data will get streamed to the payer, and payer will be able to monitor if there is any adverse events that might be happening or are about to happen. So potentially imagine a day that somebody could be sitting in a restaurant and you could have paramedics arrive and say that we got this signal and you are having a slow stroke. And we need to take you to the hospital to put you in a blood thinner or something like that. And they can prevent a massive, stroke from happening, which was in the building, just by intervening in real time. That day will come. But then you may ask me is, why do you think that I will give access to this data to the payer? Because payers are going to offer you a discount. If you don't wear this device, your insurance will be 40-50% higher. If you wear the device, it will be 40-50% lower, which given the choice, I would wear any day personally, and I think many people will make that choice. Next slide, please. So this is what I'm going to end on. There is a lot of talk about, well, will AI replace humans? I think AI has ways to go before it can replace humans, if it ever will. But I think we can use these intelligently towards creating opportunities for us that we can leverage. And our human mind has incredible potential. We have evolved over the many centuries, and we will evolve to do things that AIs cannot do. And as a society, we will get better because we will take our functioning and our faculties to a higher degree of, higher degree of working. And that will create more opportunities and a better environment for the society in general. So therefore, I feel that we should welcome AI. We should not be scared of it. Yes, in certain instances, it can do things better than us humans, but we will move on to do things that it cannot do, and we always have. So therefore, this is, from my seat at least, a very exciting development for humankind. And with that, I will end. Thank you very much for having me.
Thank you, Ashish. Now we're going to take questions from the audience, and we have several of our speakers on today to answer them.